Afternoon. Thanks for the invitation. So my role today is really to discuss with you guys, is it BPD or is it gastric bypass the best operation for patient with BMI greater than 50? This is just my disclosure slide here. Well, what do you mean by patient with BMI greater than 50? These patients have significant more comorbidities. They are actually at high risk for perioperative morbidity and mortality. And from a lot of the literature, they actually have associated with low weight loss in comparison to their counterpart of BMI patient with less than 50. So whenever you look at an operation for a subset of patient that's BMI greater than 50, you're going to have to weigh between the benefit and the risks. As you can see here, both the operation, the gastric bypass, and the BPD can produce benefit for this subset of patient. However, if you look at the risks here, I think there's substantial increase in risk associated with the BPD. So looking overall, how do you judge a good operation for a subset of patient? And these are the criteria I go by. Number one, it has to be low risk, meaning low morbidity and low mortality. Number two, it should produce high efficacy in terms of weight loss and resolution of comorbidities. But beside that, there's two other factors that's very important. Third is it has to be well accepted by the patient. If the patient doesn't accept that operation, then it's not a good operation. And last but not least, it really has to also be well accepted by the surgeon. That's us here. If the operation is too technically involved and the surgeon can't perform it or can't perform it with low morbidity, mortality, then again, that operation is obsolete. So I'll start with the first one, that gastric bypass is associated with low risk, low mortality, and low morbidity. I mean, we came a long way with gastric bypass in terms of learning it and incorporating the laparoscopic approach. This is just an early paper looking at 60 patients with BMI less than 50 in comparison with 60 patients with BMI greater than 60 here. The mean body mass as shown here, but as you can see here, patient with BMI greater than 50 associated with longer operative time, but not tremendous here, with slightly higher overall complication rate, but not statistically significant here, with no conversion and no mortality. A larger publication of 291 patients with BMI greater than 60 here in comparison to 3,400 patients with BMI less than 60 here. And you can see here again, bigger patient, definitely associated with longer operative time, longer hospital stay, but a similar 30-day mortality, which is quite good here, 0.15% in comparison to 0.12%. If you look at the meta-analysis done by Buckwall here, looking at the trends in mortality of bariatric surgery in comparison between the two operations, the gastric bypass or the gastric BPD, the BPD, as you can see here, laparoscopic gastric bypass has approximately 0.16% mortality in comparison to 0.76. So it looks like there's a fourfold increase in the mortality between the gastric bypass and the BPD. So if you look at the morbidity and the risk, definitely the gastric bypass win. What about the efficacy in terms of weight loss and resolution of comorbidities? Well, gastric bypass is not just a single operation here. There's a lot of modifications to this operation, and a lot of modifications were introduced secondary for the super obese population, especially increasing the limb length, and also there's a lot of publication now about banding the gastric pouch at the time of the operation. This is one such study, Gleistein, looking at altering the limb length here, starting with 50 centimeter, 150, and then ending up with 250 centimeter. The conclusion from this study demonstrates that longer root limb improves weight loss in the super obese patient, but did not improve weight loss in the morbidly obese patient here. So the subset of patients that actually benefit from the long limb gastric bypass is really the super obese. Here's another study looking at the long limb Roux-en-Y gastric bypass, and they found it to be more efficacious in treatment of type 2 diabetes and lipid disorder, particularly in the super obese. They divide the subset of patients into two groups. The first group is 150 centimeter roux limb, and the second group is an increase in both the biliary to 100 centimeter and the roux limb to 250 centimeter. And you can see here, controlled diabetes is better in group 2, 93% comparison, 58%. Control of lipid disorder is better in group 2, 70% in comparison to 57%. although excess weight loss is slightly high, but not statistically significant here. So they conclude that longer biliary and root limb achieve better diabetes and lipid control in a subset of the super obese. And this is data from Mark Besler looking at banding the gastric bypass here. This is, I think, initial result of 46 patients who underwent banding versus 44 patients. And actually, at 3 years outcome, as you can see here, the weight loss is significantly better for patients who underwent the banded gastric bypass in comparison to 58% for non-banded, with no mortality and no band erosion at follow-up at 36 months here. And again, to stress the excess weight loss and also the diabetes resolution here, this is systematic review meta-analysis by Buckwall here. The weight loss is similar in terms of meta-analysis between the two groups here, BPD and gastric bypass. You can see here banding significantly lower here. I have to grant it that diabetes resolution is better with the BPD, 96% here in comparison to 71% with the gastric bypass. But does that mean that everybody should be performing the BPD? But if you look at, again, you have to stress on the risk of this particular operation for the BPD here. The risk is 1.1% mortality in comparison with 0.5, and I think the latest data is actually even lower than that. So there's more than twofold increase in the mortality associated with the BPD. What about, is it well accepted by the patient here? Well, the primary problem with the malabsorptive operation is definitely nutritional deficiency and also malnutrition. As you can see here, iron deficiency can occur up to 60% of the time, and malnutrition occurred to 16% of the time here. So there are alteration of the operation, meaning increase in the length of the common channel, and by doing that, there is reduction in these. However, it still exists. And last but not least, I have to emphasize that, again, you know, the way you can tell a good operation is that it gets incorporated in the practice by the surgeons. And just use an example of a laparoscopic operation, for example, laparoscopic gastric bypass. Now, that is a good operation here. So penetrance of laparoscopic bariatric surgery, specifically the gastric bypass in 1999, there's less than 5% of the operation being done with the laparoscopic approach. In 2002, it was about 15 to 25%. By 2004, the number of laparoscopic gastric bypass exceed that of the open gastric bypass. And in 2009 here, as you can see here, about 90% of the operation now are being performed using the laparoscopic approach. This is how you can tell you have a good operation, is that good outcomes and good incorporation into clinical practice. If you look at the data, this is actually the latest data from the BOL database. I have to correct the last speaker, is that the #1 operation currently particularly a lot of these are really from Center of Excellence here in the US. So the #1 operation is truly the gastric bypass with 55%. This is probably the most accurate data here submitted to the BOL database here from more than 800 surgeons and 450 facility, so accounting for approximately 58,000 patients. As you can see here, gastric bypass #1, gastric banding to follow at 40%, sleeve gastrectomy 2%. And you look at BPD, 1% here, and the vast majority of these operations up here are laparoscopic except for the BPD, which majority is being performed using the open approach. Another questionnaire looking at the worldwide, and so that was really the US data. What about worldwide? How is that in terms of the penetrance of the BPD? Well, this is 2003 data here. This is really a questionnaire, so you're going to have to take these numbers with somewhat with a grain of salt here. But overall, BPD probably encompasses approximately about 5% in comparison to gastric bypass, 65%. And if you look at the updated questionnaire sent to the IFSO nation here in 2008 here, slightly more banding, 42%, then gastric bypass, 40%, sleeve gastrectomy at 5%. And then BPD is even lower than that. And all category of procedure has increased in absolute number except for the BPD. So just to conclude that gastric bypass, it's definitely a safer operation than a BPD or a DS. Majority of these operations are being performed laparoscopic approach, which has been shown to have better outcomes compared to the open approach, while the majority of the operation that of the BPD are still being performed using the open approach. There's good weight loss and resolution of comorbidities. There's actually variation of the operation that we can do to increase the efficacy, including increase in the biliary and root limb length, and also banding the pouch to improve the weight loss here. It's definitely better tolerated by the patient than the PPD, and it's currently the most commonly accepted operation by bariatric surgeons worldwide. Thank you very much.